I would now like to welcome Dr. Subhash Prasad, who will be speaking on sudden shallowing of anterior chamber during phacoemulsification, and he will be also speaking on sudden deepening of anterior chamber, which is some of the dreaded complications that we can have during cataract surgery.
Good morning, everyone, and thanks, Dr. Satyajit, for including my talk in your IC. The one which was supposed to be presented by Dr. Harsul could not be, so he asked me to present in the morning. So there will be some little bit of uh, here and there. So please bear with me. So yes. So we all know that cataract surgery is almost nowadays very safe surgery because of the advancement in the technology and the machines. But sometimes we'll end up with lot of problems. And one of the problem which we encounter in our, very rarely, but we encounter in our practice is, you can say that extreme shallowing of the AC during the phacoemulsification, or you can say hard eye. It's not opening. Close. This is small video clip. This was taken long back when I was using Infinity machine. This was a very hard cataract of grade 4, or can say more than that, very hard brown cataract. While I started doing phaco, suddenly I could find that the AC was getting little shallow, and I was having little difficulty and doing all the maneuver. So I thought I would stop and put some viscoelastic sodium hyaluronate kind of thing, and then we'll redo the emulsification of the nucleus. And so I did that, removed the side this chopper, and as soon as I came out, I found that the iris was coming through the main wound and even through the side port. So because of my ignorance, I just went on putting more viscoelastic. I thought that it will push the everything behind, and the chamber will become will be very amenable to surgery. But to my surprise, it was not going, and the chamber was not forming. So this reminded me of one of the condition which was described by Law OC way back in 2014. He observed that during the cortical aspiration, he suddenly noticed shallowing of the anterior chamber with rise in intraocular pressure with firm globe, and there was iris prolapse in each case. So he termed this case acute intraoperative rock hard eye syndrome. So generally the shallow eye, or you can say extreme shallowing of the eye, may not be because of that only, but there can be some other causes, like mild shallowing can be due to tight speculum, retrovalvular hemorrhage, periorbital hemorrhage, subconjunctival hemorrhage, even sometimes if it is very massive. But if it is of extreme degree, then most likely it is because of the fluid deviation or misdirection syndrome or suprachoroidal hemorrhage during the phaco procedure. So what is that, this fluid misdirection syndrome? There is diversion of aqueous or balanced salve solution behind the jonulo-capsular diaphragm into the vitreous, and this creates high pressure in the posterior segment, which causes pupillary block and angle closure as the lens and iris are shifted forward, and this leads to rise in intraocular pressure. And since it acts like a valve, so whatever fluid goes, it goes behind, it's not coming entirely, so the chamber gets becomes shallow and shallowing, and further gets more problem. So the fluid misdirection can occur in various stages of the phacosurgery, like in hydrodissection. If you inject the VSS through the jonules in the vitreous, instead of lifting the anterior capsule, if you push the lot amount of fluid in the through the jonules, it can go into the vitreous, particularly if there is jonular dehiscence. If there is VSS trapped behind the nucleus during the hydrodissection, it can also lead to the hard eye. And if there is PCR with entrapment in the vitreous, that can also lead to sometimes during nucleotomy. If there is forcible direction of the fluid posteriorly, and if there is cohesive OVD which is not allowing the fluid to come into the anterior chamber, that can also lead to that, and sometimes in cortical aspiration. So what are the management? So first thing is that avoid injecting further fluid, assess the situation, lower the bottle height, and pinpoint the possible etiologies and quickly try to manage, because this is going to lead into further problem. If there is tight speculum, you remove the speculum, or you can just start intravenous mannitol, And if you proceed without doing all these, then you can land up in multiple problems like risking the posterior capsule, injuring the lens, and endothelial injuries. So if it is so severe that you are not able to manage that, it's better to abort the procedure and let the eye settle for 1 or 2 days. Then you can go ahead with the subsequent day and reduce the vitreous pressure. That can be either done by intravenous mannitol or the procedure which is I am going to tell you. But you have to rule out whether the patient has developed suprachoroidal hemorrhage or not. But suprachoroidal hemorrhage occurs very fast, and the patient will complain of severe pain, and there are some predisposing factors like very old age patients with hypertension and particularly very hard brown cataract. And to rule out that, you have to do indirect ophthalmoscopy on the table, and it is not possible, better to postpone the patient and do V-scan ultrasound. And if you suspect suprachoroidal hemorrhage, it's better not to do anything and let the suprachoroidal hemorrhage subside, or you can just drain it also later on. Once the suprachoroidal hemorrhage has been excluded, you should do maneuver to equalize the pressure between the anterior and posterior chamber, and for that you have to aspirate the collected fluid, which was actually suggested by the previous, the inventor actually of these conditions, or you do a pars plana automated anterior vitrectomy, which is the most desirable thing. So pars plana vitrectomy, we all know how it is done. Just now sir has told you how you do anterior vitrectomy also. So you take either 23, 25 or 27, whichever gauge vitrectomy cutter is available with you. Almost all phaco machines have that. So you go 3.5 millimeter or 4 millimeter behind the limbus and just go behind the, point it towards the center of the globe. If you can't see the tip of the vitrectomy cutter probe, then it's better to mark 10 millimeter from the tip, so that you don't go that much into the vitreous chamber that it can injure the retina. So 10 millimeter line is very safe distance, and you just press once or twice. There is no need to do complete or more vitrectomy. Just press once or twice, and just 0.2 cc of the vitreous volume, if it is taken out, it will solve the problem. And at the same time, do the gentle palpation of the globe to verify that the globe has been softened adequately, and then inject the viscoelastic through the paracentesis to deepen the anterior chamber. So this was exactly done here, but at that time I didn't have the small sized probe, so I used actually the 20 gauge vitrectomy cutter, but that served the purpose. Here I am just going behind and taking just small amount of vitreous, and then I was able to form the chamber, and subsequently the phaco went very well without any problem, like any routine case, and I was able to implant the lens, and you can see the red glow later on also here. So everything was as we get in the normal phaco cases. So multi-pitch lens was implanted as it was suggested by the patient. This is the case where I encountered this problem during the irrigation aspiration. See, this was mature intermittent cataract, and everything was fine. But while I was injecting the lens under the irrigation, the hydroimplantation, it did not go into the bag and started just moving in the anterior chamber. And I could see that the chamber was extremely shallow and was not able to place the lens in the bag. So, and it was a single piece, so I would not have let it remain in the sulcus also. So I thought it's always to place it in the bag, but bag was not allowing me because there was severe pressure from behind. So I went ahead and did the same thing, and I just removed a small bit of vitreous, and then everything was solved, and I was able to place the lens in the bag. And subsequently this was 23 gauge vitrectomy cutter, and then I'm doing the IA. Another case here, while doing the cortical aspiration, you can see that the iris was coming little bit. I thought that there is probably the intraocular pressure is little bit high, or it was being done with the Infinity machine, so I thought the bottle height was little more. But to my surprise, despite forming with the viscoelastic, the iris kept on coming from the two sides. You can see here, just like and the globe was very tight, very hard. So again I went ahead and then removed a small bit of vitreous, and this solved the problem. So this is very useful technique of just removing or decreasing the intraocular pressure, which is very high during intraoperatively when mannitol any other things are not going to work. So just to summarize, hard eye is very challenging situation of some of the cases. Timely intervention can prevent further complications, and one has to rule out suprachoroidal hemorrhage before resorting to pars plana vitus step, which is very safe and very effective in such situations. So thank you very much.